Good morning. Can you be my ears? Is this working? Okay, thank you. Welcome. It's good to see all of you. For those of you who were here in March at the Ducks in a Row Forum, this is the exact same presentation. I'm just repeating the presentation. Some residents approached me and said, please repeat it again. And others said, I didn't make it to the Ducks in a Row, but I'd like to get the same information. So this is a presentation I used to do once a year, usually before the pandemic. And I usually also offer this for waitlist prospective residents. So I'm happy to share this again. It's a lot of information. And so this is really to make sure you're all aware of what the support and service options are for you as an independent living resident. And so we are going to talk about the continuum of care here at Horizon House. And we are a life plan community or continuing care retirement community that offers the full continuum of care. And some of the things that we will talk about, and by the way, most of you know I'm very informal, so please don't hesitate to ask questions throughout. It's oftentimes, I know, helpful to ask in the moment rather than having you wait till the very end. So don't hesitate. And for the benefit of everyone hearing each other, I'm happy to run around with the microphone so we can all hear the questions that you're each asking. So we're going to talk about what it means to live independently. And so I'll reflect on the conditions of occupancy, the services available to independent residents, what happens if you have to go to the hospital, and post-hospitalization options. And then we'll talk about assisted living and the services offered there, as well as some examples of residents who may have a short-term stay in assisted living and some common reasons why residents who do transition to assisted living, what those reasons are for permanent transitions. And of course, some cost and insurance application in assisted living and more Q&A time. So for independent living, what it means to live independently. You may remember, for those of you who in February of this year attended the resident board meeting, I announced just very briefly in that portion that the board at its meeting earlier, prior to the residents coming, had passed a revised conditions of occupancy document. And this talks about how Horizon House endeavors to support individuals in their residences so long as the health, safety, and related requirements for the residents' conditions of occupancy are satisfied. The reason behind some of the changes that I'll highlight is we've been getting a lot of feedback from many of you, residents here, about concerns of other independent living residents who are showing changes. And I described back in February, and I think in March when I gave the same presentation, I'm describing it almost as an imbalance in the resident community. And two factors. One, there have been concerns expressed by some of you about the residents who are newer to the community coming in with more challenges. And I also have been hearing from a number of residents for quite some time about concerns of long-term residents who have been showing decline over a long period of time. And what are we doing to help support those residents? I'm hearing some of you say, are they really safe to be in independent living? And so that led to some good conversation about conditions of occupancy. And that is a document that is a part of your packet, your residency agreement packet, as I understand, that started becoming a part of the residency agreement packet in 2016. And prior to that date, it was part of the resident guidebook, I believe was the term used. So it is now, as of 2016 forward, a part of the residency agreement. So some of the changes that were made to the conditions of occupancy earlier this year is to call out some specific elements of what is required to be safe and thriving in independent living. So residents must be able to, in order to effectively live in the independent resident community, must be able to follow emergency procedures. That was one of the big concerns that was coming forward from residents is, I'm not sure that my neighbor would have the ability to know, because of cognitive limitations or physical limitations, what to do in the event of an emergency. To live independently, we need to ensure that residents can properly operate appliances. We do have situations of some residents who are showing some changes in cognition, not being able to operate the stove safely, microwave safely. We've had situations where residents, in some cases, will call the front desk repeatedly with TV issues, and it is because of cognitive challenges and inability to operate the remote control. So things like that are glaring indicators that there is more that is a challenge for a resident who can't operate, for example, a television remote control. We need to ensure that residents in independent living can safely navigate the community. When we start to hear about independent residents wandering or coming to the front desk lost, that's a concern for safety. Being sure that residents are free of offensive odors and soiled clothing. Occasionally, we have had residents who are starting to appear more disheveled or showing a lot more clothing stains or wearing the same clothing day in and day out. Those are triggers for concern. We want to be sure that residents in independent living can independently manage home care providers and have the ability to recognize when care may not be being provided per the agreed upon plan of care. And another factor is when a resident starts to overutilize resources, frequently coming to the front desk, frequently submitting work orders for things that are not really broken, or frequently calling the front desk for help for the same issues over and over and over again. That does occur. So again, those are things we want to take note of and help to support residents with getting support in place that would help them to be safe and thriving at their best. The other aspects of conditions of occupancy have to do with the changes of what I've been talking about in physical, cognitive, or emotional health that impact safety and function. So when we have residents, for example, with repeated calls for the nurses, if we have an increased number of falls that are not because of an acute issue, but because of a chronic issue and repeated falls, if we have an increase in residents relying upon neighbors or family to help support them in independent living, those are all triggers for us to understand we need to look at what is going to be best for the resident and their safety and care. Unsafe behavior. So if we see residents who are threatening their own safety or the safety of others, or wandering, I mentioned already, or threatening behavior towards staff, those are all part of the conditions of occupancy. And so we use that information in those conversations with residents and family members to talk about, we need to look at what support is going to help you be safe where you are. And sometimes that may be in the form of a transition to assisted living. But again, we want to do everything we can to understand what support can help you remain in independent living for as long as possible. And we'll talk about some of those supports. So moving on to some of those supports, I'm going to highlight reminding you of your access to a nurse 24/7. I'll briefly touch upon that. I'll highlight home care as another option, home health, your access to outpatient rehabilitation services, care management, the ancillary providers available to independent residents, wellness programs, inner well-being and spirituality, as well as end-of-life choices and what to do about resident decline or concerns. So I'm going to briefly highlight these areas to, again, reiterate the support options available. So starting with emergencies, should be a reminder to all of you that you have access to a nurse 24/7. Those nurses come from assisted living. So in your apartment, there should be a pull cord in your bathrooms. You have access to your phone, of course, and you are all issued at the time of transition into Horizon House a pendant. I know some of you choose to wear that on a lanyard, some choose it as a wrist watch, and many of you choose not to have the pendant on you. That's a personal choice. My strong recommendation is if you are starting to experience changes in your physical abilities and or some cognitive abilities, really encourage you to get those pendants on. You just never know when you might have a mishap of some sort or a fall. And if you can't get to the phone, it's really great to be able to have your pendant as a backup. I know some of you have shared to keep your pendants on your nightstand for nighttime, so it's a personal choice. If you've lost your pendant, please go to the front desk for a work order to have a new pendant issued. So make it a goal today. If you haven't used your pendant in a long time, go check and make sure you still have it or that you haven't lost it. So when you do activate by phone call, pendant activation, or pull cord, that sends a signal to the front desk and they will dispatch a nurse. Per the protocol, because we have a number of false alarms, the protocol is for the front desk to call first. They should be calling the apartment first to confirm if you need a nurse or is this a false alarm. If nobody answers, they will dispatch a nurse. And then the nurse will come, do their assessment, and the outcomes are they may recommend you go to urgent care. They may recommend you go to your emergency room. They may call 911 for you, or it could be other. And a reminder that we implemented in January of this year a $50 charge for non-emergency calls. And that was implemented because we were receiving a fair number of calls for things like, can you help me off the toilet? Can you help me back into bed? And that's not using our nurses wisely, and we have to preserve that important resource. So this was to help deter some of the overuse of those circumstances. The other thing I want to really put in a plug for with emergencies is to make sure you have your vial of life. Those were issued several years ago, and we have that form available if you need to make changes on HH Connect. And that is a document that should contain some important information. Your emergency contacts. We want this to speak for you when you can't speak for yourself. So you want it to have emergency contacts. I recommend that the vial of life includes your hospital preference. I know some of you are very clear. If I need to go out emergently, I only want to go to Virginia Mason or Swedish or Harborview because that's where your medical records are contained. So pieces like that are important to note. If you are a part of a body donation, if you're found deceased and you have an alliance with the University of Washington to donate your body for research, include some information on your vial of life. So that is what first responders, our nurses or 911 are going to look for to understand some information. Most of you have that either on the back side of your front door. Some have it in the freezer. Some may have it on the side of the refrigerator or freezer. I worked out several years ago with King County Medical Services. They have in their database that if 911 is summoned to 900 University, what pops up is we have vial of lives here. So the 911 responders will be looking for that if they come to your apartment. I want to emphasize, any of you are empowered to call 911. You don't have to go through the tower nurse. If you feel you have a 911 situation, don't waste your time for the tower nurse. Call 911. If you have the ability to do so or a bystander, have them call reception because then they can get facilities in line of security to hold the elevator. So we want to expedite 911 getting to you. In that packet, many of you I know have it in a Ziploc, gallon-sized Ziploc bag. I recommend having your post form in there. And I always recommend every time you go to the doctors, have them print off your current medication list. Have a copy of your medications in your packet. That's helpful information. So for example, if you are on a blood thinner, you're going to bleed more excessively, likely, if you have an abrasion or have a fall, and that is helpful information for 911 or nurse responders to understand that. Any questions on vial of life? Nancy?
Yesterday at the Ducks event, we mentioned the red sticker that a lot of people don't use. And so one of the suggestions by one resident, which I've done, is to put the red sticker on the outside of my door and using a black felt pen, I write where the vial of life is, because we don't want people running around trying to find it.
That's certainly an option. Some of you have the red vial of life sticker. Nancy was saying that some have chosen to place that on the outside of your door. That's strictly optional. I've had some residents say they don't want that as part of their door aesthetics. That's a personal choice, but what I can tell you, it is very standard amongst EMT and first responders to look for the vial of life in the freezer, on the side of the refrigerator, and in, again, the 900 address, it does pull up that also the back side of the front door. But thank you, that's absolutely a personal preference and certainly a welcome if you choose to do that. So moving on to some other support, home care. So just to remind you all that home care is a service that is an option for you. Physician orders are not required if you choose to use home care services. These are personal services in nature. So home care are typically private caregivers. They usually are nursing assistants or nursing aides certified. And they help with primarily self-care tasks, things like dressing, bathing, grooming, perhaps toileting, transfers. Some of them might help with laundry. Some of them might help with cooking, doing some grocery shopping for you. So home caregivers are primarily assisting within the realms of self-care and basic household type of chores. And I'll speak more in a little bit, but we do have the private caregiver policy, and I know I sent out some information on that very recently at the end of May. And so we do require that any private caregivers serving residents here in independent or assisted living, that they must be employed by a home care agency, a licensed home care agency, and that's for some safeguards. That we adopted that private caregiver policy many years ago because there were concerns about who is overseeing these caregivers, who's ensuring that my neighbor or my friend receiving services is getting good care. And so that private caregiver policy is in place because it is a state-regulated program. Department of Health oversees licensed home care agencies, so there are surveys that occur. They must meet certain conditions to operate a home care company, so those safeguards are in place. Judith, did you have a question? Let me...
Go back to the toilet, the person needing help getting back off the toilet seat, back to her bed or his bed. Oh, okay. What do you feel? You said it was inappropriate for the nurse to have been called in that instance. So what do you do when someone in the middle of the night or whatever has a problem with mobility? They can't go hire someone in the middle of the night. So what should that person have done rather than call for the nurse?
What I'm saying is, in those cases, when the nurse is called, there will be a $50 charge, and what we're looking for, Judith, is if that's a reoccurring issue, then that then triggers the conversation about, let's look at what support might be needed, such as home care.
So it was appropriate to call the nurse.
We're trying to deter that type of nurse support, because nursing is a precious commodity. So in the case where a nurse is called, of course, the nurse is going to respond, and there will be a $50 charge because that's a non-emergency use of the nurse. If we see a pattern emerging where a resident is calling repeatedly, as we have done, then we start to talk about a requirement for some home care support, because we can't rely on the nurses to be coming to do transfers. Also on home care is private pay. So that is a private pay service unless you have a long-term care insurance policy, and if your insurance policy covers home care as one of its covered entities. Some long-term care insurance policies do and some don't. So that's important to check if you do have a long-term care insurance policy, if they provide coverage towards home care services. I will tell you, as an occupational therapist myself, most long-term care insurance companies will not pay unless you have a need for assistance in at least 3 self-care areas. So that is usually a very common requirement to qualify for coverage with your long-term care insurance. On home health, completely different beast. That is provided under the direction of a physician. So in other words, there have to be physician orders in place for home health services. To qualify for this service, one must be considered homebound, where it would be difficult for you to travel out of your home to receive care. This typically follows a short-term hospitalization or skilled nursing rehab stay. This is typically when we see home health come into the picture. It's an extension of that type of acute care that you've received. And typically home health is in the form of nursing support, maybe physical, occupational, and or speech therapy. And typically this is short-term. So a very common scenario is a client or a resident who has had a hip fracture, have hospitalization, surgery. You go to skilled rehab for a couple of weeks, 3 weeks. If you're able to transition back to your independent apartment, then you will have likely some home health follow-up for more ongoing physical therapy, 2 days a week perhaps for several weeks, and then you may graduate then to outpatient therapy once you're no longer homebound. Mobility is improved, you have the ability to leave your home to go to therapy. Then you would no longer qualify for home health, would transition to outpatient therapy. So that is typically an insurance-covered type of therapy or nursing services where you can capitalize on your insurance benefits. We do have some scenarios where residents return from hospital or skilled rehab. They have both home care and home health. So home care is providing the general daily self-care support, while therapy through home health is helping you continue to make more progress following an acute injury or medical event. So very common to see them both used simultaneously. And for nursing, typically what we see for nursing in home health is when there is a new wound that requires dressing changes or bandage changes that is extensive, then typically a resident will qualify for some home health nursing to continue monitoring that wound through healing. New diabetic, very common to have some home health nursing to continue once a resident returns to their apartment to qualify for some home health nursing for ongoing training on managing your diabetes. So those are some common examples of home health nursing, again, short-term usually. And from there, I mentioned a moment ago, outpatient rehabilitation services. We've got Divya back. She has started her own private practice with the unfortunate closure of Infinity Rehab due to decreased Medicare reimbursement for outpatient therapy services. So unfortunately, that led to Infinity having to close doors in February, and they had to close, I believe it was 18 of 21 outpatient centers with a rise in labor cost and decreased Medicare reimbursement by 3% as of January this year for outpatient services. It necessitated closing their doors. But we're so fortunate that with that closure, we've been able to bring back Divya as she started her own private practice. Divya does have contacts for occupational and speech therapy colleagues for any of you who may have a referral for either of those services. So I just feel so grateful that Divya is able to be here because I know that's a highly valued, used service by many of our residents. Nancy.
I'm covered under Regents, and I just got a letter yesterday saying Divya is not going to be accepting my work. And I've got it coming, so I'm not sure what I'm supposed to be doing. But I can't use her, and I'm just in tears over it, really.
That's so unfortunate. It's getting really difficult with insurance companies who often I find are shrinking their networks of providers. The next closest outpatient therapy service is right across the street at Virginia Mason. So you can try contacting Nancy Virginia Mason Outpatient Services to see if they accept Regents. It's unfortunate. I know that Divya is continuing to make efforts to try to get credentialed with more insurance companies to be able to see more residents here. David.
Lori, what is the definition of outpatient, what is the definition of outpatient out of Horizon House? Yeah, out of Horizon House and on your own, but you arrange for it. It's not a Horizon House benefit as such, is it?
So outpatient rehabilitation services is the general term used everywhere. So it is a definition that defines therapy services when one is no longer qualified for homebound or home health therapies. So outpatient therapy services is a service we don't provide directly, but we partner with Divya to provide outpatient physical therapy here at Horizon House on the B1 level. And if there are any residents with speech occupational therapy referrals, Divya has contacts she can call on your behalf to have them come to Horizon House for those outpatient services. So outpatient does not mean going out of Horizon House unless your insurance does not accept Divya's practice. And there are insurance companies that are very strict in what insurance and providers they use in the network. So you would have to make a decision if you elected to continue with Divya at an out-of-network cost or pay privately. Okay. After outpatient services, care management. That is yet another support option for some residents. So care management, that is a growing business, especially as the population of older adults continues growing. This is an area that we're seeing more and more people get into the business of. And so therefore we expanded, as you well know from a memo I put out at the end of May and announced at the May Fireside Chat. We expanded our private caregiver policy to include both private caregiver or home care and care management. Care management is a business or service that is not regulated by any state agency, much like home health and home care are. And I wouldn't be surprised, especially as the number of older adults grows, and because of the common definition of vulnerable older adults, I would not be surprised if at some future point care management falls under regulations. I wouldn't be surprised at all. But in any event, physician orders are not required for care management services. And per our policy and what is standard in the care management industry, we are requiring that any care managers providing service here at Horizon House must have one of these following credentials. They must be a master of social worker. They must be a licensed social worker or a registered nurse or a licensed practical nurse, an occupational therapist, or a certified geriatric care manager. When you work with professional care managers, they will have one of these credentials. So we simply wanted our policy to mirror what is standard in the industry for your protection and to ensure that you're receiving qualified, trained services. Care managers typically provide one-on-one support. These are not self-care in nature. Any services around self-care support must fall under the licensed home care. That is by state definition, not Horizon House. So in other words, people serving as care managers or under a care manager, someone serving as a companion or an engagement specialist should not be providing support with toileting, bathing, dressing, transfers, any of those things. If those individuals are providing that type of support, they are crossing a boundary line and rendering what is technically called home care services. So if that were to occur, we would want to know about it so that we can follow up and ensure they are operating within their professional lane. And these individuals, typically, they might be called in. Very common to have this when family members may not live in the local area, and there's a chronic health condition at play, or perhaps a dementia process. And so some residents might want to have a care manager who can help manage appointments, help manage what support might I need as I continue changing through a chronic health condition, for example. And under care managers, they may, through their assessment, this is why one of those credentials is so important, because they're rendering assessments. They're rendering assessments of a condition, of the person's abilities to understand what support would be best for them for their, again, best well-being. And so sometimes they will bring in other team members who might serve as a companion or might serve as an engagement specialist. And so both of those types of individuals who support people would be under the supervision and training of a care manager. So that is another option of support available to residents through care management entities. This is a private pay. And again, just calling out again that we have the home care, private caregivers, and care management policy. Just a reminder from the memo and communication at the May fireside chat, a memo and mailing went out to all home care companies we know of who are providing services here. And that same mailing went out to all care managers that we know are providing services here, outlining the policy and that we are requiring a licensure provision for those with home care company. And we also are requiring the certificate of insurance to confirm that all home care and care managers operating here have the insurance, so for liability reasons. So that information is starting to come in as they have a deadline of July 1st, and we want to make sure they're in good standing and have all of their ducks in a row to be providing professional and trained services here to all of you. Moving on, ancillary services. This should be a reminder for hopefully all of you as just we do the overall holistic comprehensive review. We have acupuncture services here, audiology, we have a dental hygienist, massage therapy, and podiatry. This is a combination of insurance. I know some of these providers will provide you with information to bill or send to your insurance for claim, and some of these are private pay. And of course, you can schedule these services with concierge. I know some of these providers will do direct bookings with you for appointments, so it's on a provider by provider basis. And for wellness, hopefully most, if not all of you, are using and tapping into that amazing service. We are so fortunate to have three wonderful individuals with Brian and Deborah and Andrew. And so, you know, they really work hard to provide a holistic overview of wellness offerings and to design to really look at the holistic well-being. And, you know, I was very intentional through the hiring process of making sure we brought in team members who just aren't land-based, fitness-based. I wanted to have more depth for the offerings, as long as it encompasses movement. And we have that with Deborah and Brian and Andrew. We really have just a breadth of background and experience to offer more variety, because not everybody wants to just go to the gym and use machines, and not everybody wants just physical stretch exercises. And so we're very fortunate to have terrific wellness staff members. And so, as you know, they work hard to provide more of the BEAM, Balance, Exercise, and Mobility Center programs to really focus on fall prevention and balance. And they also are really focusing on joint mobility, muscle strength, static dynamic balance, gait enhancement through their classes, strength and stretch classes, as well as a host of others, including art, which is a form of well-being and stimulation. So it's just terrific. And then we also have our inner well-being and spirituality department headed up by Linda and Bill Comfort. And that group is really focused on trusting relationships, certainly abide very strongly by confidentiality. Many of what Linda and her team offer have no grounding in religion. And Linda was very intentional in being very thoughtful about changing the department name from spiritual care. For those of you who may be newer to the community, spiritual care stopped a lot of residents in their tracks, and they equate that term with religion. And Horizon House is very welcoming of people of all faiths and no faiths. And there are many residents here who feel very firmly about having no affiliation or association with religion, and therefore avoided Linda like the plague. And so I'm hopeful that many of you recognize that Linda and Bill offer amazing services completely independent of religion, but in the form of support. So Linda and her Bill provide support and discussion groups, and they are care partners managing the care of a loved one. It's a wonderful support network amongst each other for those of you who may be supporting partners or spouses with various health challenges or cognitive challenges. The men's group, Bill leads a wonderful men's group, discussion group facilitated by the participants. And transitions, this is not focused on necessarily a transition of a particular type, but of a variety of types of transitions. Can be the loss of loved ones, a partner, can be a transition out of a working role. We still have residents here who have professional work they're still doing. Can be a loss of health, of abilities, of mobility. So it's also a very rich group of sharing and support for one another. Wisdom poetry and being human. The other focus for Linda and Bill is one-on-one support. That can be in the form of grief counseling. Linda has an extensive background in hospice care as well as a counseling background, so she's a wonderful resource. She provides emotional support, support in struggling with aging process, changes in our bodies, end-of-life support, deep listening, and then other types of services. Linda and her team, either themselves or in partnership with other community members, larger community members around different worship services, resident memorials, and individual memorial services. So really a wonderful offering amongst Linda and Bill. And moving on, just want to let you know again that we are in the recruitment process for a new care connector that we're terming care navigator. That was the position that Erica Campbell had here. And so we are under recruitment to bring back that position. And we are wanting this individual to be able to provide you with guidance and to also your family members, and ensuring, for example, that you have those important ducks in a row documents that Nancy and Cassandra have been so instrumental in helping to support. The Care Navigator can do that as well as another resource. This Care Navigator, when we have that position rehired, will help you to make sure you're managing your medications and helping you with support that might be needed if that is a need to remain in independent living. And additional services. Again, this is going to be your advocate to help you understand what support might be needed. And that support or recommendation by the Care Navigator may be to consider bringing in some home care. It might be consider bringing in a care manager. It might be let's get you set up with some therapies because it looks like you're having more challenges with mobility. So any of those types of things. I've been serving in that capacity in the interim. Again, with my occupational therapy background, I'm well suited for that. And I will continue being your point of contact until we have that position replaced. So please don't hesitate reaching out. I've been working with a number of residents and family members, and it's been really a gift to be able to pull my occupational therapy hat back out and to be of support to those residents who have needed support. So I'm happy and honored to do that as we're recruiting for a new team member. And let's see, end-of-life choices. Just want to reiterate again that Horizon House here supports your choices around end of life. And I so appreciate, I just have to say again, so applaud the efforts of Nancy and Cassandra and all that they are doing to bring their expertise in helping the community to have those open conversations around end-of-life choices. And so just to reiterate again, the importance of all of you having your advance directives in order. Nancy and her team have done a terrific job of highlighting the different types of advance directives now available, unlike before. I mean, it's amazing to now have a dementia advance directives in place. Can't emphasize, that type of a directive is so critical to get in place while you have the capacity to execute that and to clearly state your wishes should you come with dementia. So just really emphasize to please have that in place. Please have your post in place so that you can have that document speak for you if you can't. If you are found unconscious in your apartment, we want to know how do we respond. 911, our nurses, and we're going to be looking for that pulse to understand, do we start CPR or not? If you're without a heartbeat and without, a pulse and not breathing. So have these documents in order. Please, please. Nancy, any extra pitch you can put in, please.
We talked about this yesterday at Got Your Ducks in a Row. The pulse form was changed in April of 2021. So we're recommending people look at their pulse form. If it was created before April 2021, it's good to get a new one because there's additional information on it that's really helpful.
Thank you, Nancy. I always advocate that if you are hopefully going for your annual well checks, review it with your primary care providers. It's a good time to just review and make sure your wishes are still reflecting. We experience condition changes, and as we get older, that becomes more common. So I think it's wise to review that with your primary care provider on an annual basis. Thank you, Nancy. Yes, Gloria.
If you want to get a miniature size pulse, you can go down to the any kind of a place like Kinko's, and they'll shrink it and laminate it, so you can carry it in your purse. And if something happens when you're out and about, you have something to show in the emergency room.
Thank you for that tidbit. I know that some residents have elected to haven't heard about it in a long time actually, but an ID bracelet. You have to pay for a monthly subscription where 911 responders can scan it and it pulls up your advance directives. But there is a monthly subscription. I just want to reiterate that, again, some residents choose to participate in voluntarily stopping eating and drinking, or VSED. That is an option available to you. I really encourage, if you have more detailed questions, Nancy is an excellent resource for that, as well as End of Life Washington, which is referenced on here. And I just want to reiterate that Horizon House does support Death with Dignity when that came on the scene now a number of years ago. At that time, all long-term care facilities had to determine if they were going to be an opt-in or opt-out facility. And we held resident forums, and we heard loud and clear that residents want to exercise their right if they qualify, and our board adopted an opt-in. And we have had residents here, I'm sure more than I know about, who have exercised their right under the law for Death with Dignity, both in independent and assisted living. So those are really good, important, healthy conversations to have with your family members as well, so that they are well aware of what your wishes are around end of life and advance directives. Margaret.
Just want to know if this extended form is available. Excuse me. This form with additional questions on it, is that available here at Horizon House if we want to do a new one?
Yes, they are. You can get them at the front desk.
Front desk, and I believe they may, I don't know if you know, Nancy, if they're on HH Connect as well.
Yeah, but they have to be printed in green, is it not?
Yeah, all clinics and providers should have them because they have to be signed by a provider. So if you don't have one currently, next doctor visit, please ask your doctor to provide one. They all should be equipped. And that does have to have, it is not valid without a provider's signature. That's key. I have seen some residents who have made changes, good changes, but don't realize the step of needing to get a provider's signature. So that's really important. Thank you for the question. And then, of course, mortuary. Really recommend that you have a mortuary listed on your vial of life. So again, if you are found deceased in your apartment, then we know what mortuary to call after we have notified, of course, next of kin. I do want to, on that note, I do want to emphasize how critical it is that everyone here have a listed executor on file. And the reason for that is if you are found deceased or you are in the hospital and pass away or offsite and pass away, the policy is we secure your apartment. We will not we will not authorize anyone to enter until we notify and know who your executor is, who your legally documented executor is. And then it is the executor who will then authorize to Horizon House who they permit to enter your apartment. I know that some residents I have worked with believe that is one and the same as a durable power of attorney. It is not. Sometimes they are one and the same person, but oftentimes they are not. And so once a individual passes away, the power of the durable power of attorney to speak on your behalf ceases, and then it is in the hands of the executor after death. So if you have not furnished your document around durable power of attorney, an executor, please do. Sandy in accounting is the one who collects that information and scans it into a master database. It's very helpful to have that, because if you are found deceased and we don't see anything in your apartment, especially with your Vial of Life packet, then we have to spend time trying to track down who your executor is. And we've had that situation, and it's difficult, especially when you have family members calling saying, I want to get into my aunt's apartment or my dad's apartment. We're so sorry, but we can't authorize until we find out who the executor is. So please have that information available. Sandy in accounting. Thank you. Sandy in accounting is the one who you can turn that information into to scan.
What, please?
I'm sorry?
Sandy issues what?
Sandy is in accounting. She's the one who prepares your monthly billing statements. She collects durable power of attorney and executor documents and scans so that should we have a resident found deceased, we can quickly access who the executor is. Or if a resident is not deceased but has, for example, a debilitating stroke, we want to be able to notify your durable power of attorney to advocate on your behalf if you are unable to do so that your wishes can be honored. Yeah. Yes. What kind of form do we require for? What does Sandy? Oh, if you can just provide, so for example, the executor is often part of your will. And so we just need the part of the will that clearly shows the legally recognized executor. So we've had residents who have furnished just a portion of the will that reflects the legally authorized executor. And then just a copy of your durable power of attorney. For healthcare and finance, sometimes they are one and the same. Sometimes they are two different individuals. That'd be great. It's mostly healthcare we're after, because again, if you have a catastrophic medical event, then we want to be able to reach out to your durable power of attorney if for some reason they are not aware that you have had some kind of a serious injury and have been taken out to the hospital. Mm-hmm. Yes.
If that should change, if the executor is, if we should change that information, how is it sufficient to do a codicil to the will, or do we know?
Is it sufficient to just do an update to the will? Is that what you're asking?
Yes. Yes.
My understanding is at a minimum it should be notarized. Public notary. And we do have a couple of public notaries here at Horizon House.
I'm one.
Nancy is a public notary. I know Beth, executive assistant, is a public notary. Risa is a public notary. I don't know if she has now met the criteria, but yes, Jay. Jay at the front desk is also a public notary. Yeah, so you do want to have it at least notarized so it becomes more official and legal. Because otherwise, without a public notary, we don't know if someone may have been coerced. Yeah. Okay, moving on. Ooh, goodness, I do need to move on. Great questions. What to do if I am concerned about a resident? And this comes up pretty regularly. Is if you are concerned about a fellow resident, whether it's a neighbor, a friend, or staff, observe changes or concerns with residents who may be showing changes for any reason, you can share these concerns with me. And in the past, when we've had the Care Connector role, residents would either go to Erica or to me, either one, whatever, whoever's accessible. But for now, you certainly can come to me, and many of you have. And I just want to assure you that we treat those conversations very delicately and with utmost confidence. I can tell you that when residents have come to me with concerns, it is very common for a resident to say, I don't want my name to be used. And we respect that. And my follow-up when I am working with the resident whom a concern has been reported, I am not sharing, someone came and told me. I'm very thoughtful because I want to preserve dignity and honor dignity. And so my approach is to say, I wanted to connect with you and do a check-in. I'm concerned about you. I'm seeing that there may be some changes or it's been shared of, and then when I do have the resident saying, who told you that? Which is very common too, I say, this is coming from a place of caring. And that is genuine. And when any of you do come to me with concerns, I see nothing but genuine caring and wanting to ensure that a resident has the support that they need to be okay. And so I appreciate that because it is hard sometimes for any of us to recognize when we may be showing changes. That's hard. And sometimes, especially if there is memory loss involved or cognitive changes, we may not recognize that we are experiencing some changes, that things are getting harder, or there is denial that is commonly at play. And so I do appreciate, and I know that's not easy, to come forward to be able to share when you are seeing some concerns. And as staff, we can't always be eyes and ears, and sometimes you have the best pulse on what is happening that we may not necessarily be aware of. So I just want to assure you that we do protect confidentiality and protected health information if you are aware. I also want to emphasize that in return, I'm not at liberty to follow back up with you and say, here's what I've learned, or here is what the problem is. Because I am obligated by HIPAA to respect patient confidentiality or resident confidentiality. But I wanted you to be assured that that is the approach we take in following up on any concerns that are brought to our attention. And hospitalizations, just real quickly. If you need to go to the hospital, I know some of you go out emergently, and some of you go out for planned surgeries or procedures. When we are aware of you going out to the hospital, we do have staff who follow up. Currently, that's usually Amanda Rubel. In her role, she does follow up with hospitals to just understand how are things going in general and what are the discharge plans shaping up to be. Sometimes we have the residents who call us directly to keep us apprised. And sometimes we learn about hospitalizations through the grapevine. We may not always know, especially if you've been off site and have an injury or a fall or some type of a situation. Then you go directly to the hospital. Sometimes we hear about that through residents. Oh, did you know Mrs. So-and-so is actually at the hospital? We didn't know. Thank you so much. And we will follow up because we want to make sure that you're, first of all, safe, and we want to make sure your apartment is secured. And so when we do hear people out of the hospital, we will follow up, and typically some options of what can follow a hospitalization. Most ideally, I think, you want to be able to go back directly to your independent apartment, whether you've gone out emergently or for planned surgery. And so when you come back to your independent apartment, sometimes you don't need any support at all. You're fortunately able to just return and carry on. Sometimes there are changes of condition based on the hospital event, so that may be coming back to your apartment in the form of some support from home health, home care, perhaps some family support, or some outpatient therapy. Another option that may follow a hospitalization is coming to assisted living, short term, for some respite. Maybe you feel not quite ready to go back to your independent apartment. You'd prefer the safety net of having the nurses right there. That is perfectly acceptable as well. If that is the course, then we get the right assisted living team members plugged in directly with the hospital to start coordinating for that transition for a temporary respite stay. Or you may end up going on to skilled nursing facility for some short-term rehab. And I, as a therapist, put in a strong pitch. If you qualify for skilled nursing rehab, take advantage of it because it's covered by insurance. If you have the traditional Medicare, they cover the first 20 days, and then day 21 through 100. If you qualify, Medicare will pay 80%, and if you have supplemental insurance, they cover the remaining 20% usually. Now, I will tell you that in my many years' experience as an occupational therapist and having worked in skilled rehab before Horizon House, most patients don't qualify for 100 days of rehab. The ones who do, typically in my experience, have been for extensive, horrific wounds or pretty significant strokes who are showing progress to continue qualifying for ongoing therapies. So I would say in general, we typically see more in the average range of 2 to 3 weeks of skilled nursing rehab. Pretty unusual to see more than 3 weeks these days, unfortunately. I know that we have had some residents who say, nope, I want to bypass that. I just want to come into assisted living to get back to Horizon House. We have to evaluate the paperwork because there are regulations for assisted living. And if a resident, depending on the condition and their health requirements, sometimes we can't take you into assisted living if you qualify for skilled nursing based on how the regulations are written. And we will put in the plug because the more therapy you get up front, the faster and better chance of functional progress. And that's what we're after, is to make sure you have the most optimal benefit of getting back to your pre-surgery, pre-injury status. So that's what we're going to advocate for. So that is what happens for hospitalizations. We're here to support you. When we get that care navigator back in place, then that person will be following up with the hospitals to help support whatever that discharge plan might be to ensure you have the support in place. Yes.
Yes. Is it true that you have to go to assisted living? If you choose that for a whole month, you can't go for 2 weeks if that's what you need. And also, I understand Medicare skilled nursing is only if you've stayed in the hospital 3 days, which is pretty long in a hospital.
Great questions. So the first one, if I understood correctly, is it true? Can you come through assisted living if you need to for like a couple of weeks? So we recommend that for respite stays that they be 30 days because of the time involved with doing the assessment, getting to understand routines, rhythms. That's ideally what's recommended. However, absolutely, we have had residents come through for respite stay, intending to stay for at least 30 days. They do well in the recovery, and they don't need to stay for 30 days. So sometimes we do have residents who transition back to independent apartment after just a couple of weeks. And in terms of the second question, yes, for traditional insurance, and most insurances, they do require a 3 midnight stay at the hospital to qualify for skilled nursing rehab. Kaiser, I know, can waive that. Sometimes they waive that and get patients out of the hospital in 2 midnights into skilled nursing. What I will say as a strong plug, it is a pet peeve of mine. Too often, in my opinion, individuals are admitted on observation status, and it does not qualify or count towards the 3 midnight stay. And so I feel that that is a little trick to get out of having to qualify patients for skilled rehab when they should be going to skilled rehab. So if you are advocating for a loved one, a partner, or tell your children who might be your durable power of attorneys, you push those hospitals. You ask the question, am I here yourself or advocating for friends or neighbors or loved ones, or are they on observation? I want them admitted. So you want to really push to get admitted so you can start that clock ticking through towards the 3 midnights if you really are one who has a serious condition and need to try to qualify for skilled rehab. Thank you for the question. That reminded me to put in that plug. All right, we're going to move on. Assisted living, that is another option for residents. And so I want to just highlight briefly the services available, the support, examples of some short-term stays, one of which we just talked about, and some of the common reasons residents will transition for permanent stays in assisted living, and cost and insurance. Assisted living at Horizon House, it is more than one definition. It is a residential healthcare program designed to meet the social, mental, spiritual, and long-term care health needs of the residents served. We offer, as shared already, long-term residency as well as some short-term respite stays. And one of my passions here at Horizon House is the fact that the philosophy here is one of integration. And that is one of the hallmarks of assisted living here. In contrast, and there is nothing right or wrong about this, it's different philosophies. That's why when I am asked to meet with prospective residents, this is one of the clear points I make and why it's so important that all of us as consumers research more than one senior living option, because they're all unique, they're all different, and everyone needs to find the right community that's a good fit for them. In Horizon House, we believe strongly in integration. So blending our residents who are in assisted living or independent living, whereas some other communities have very strong philosophies around more separation between those in healthcare and assisted living and or skilled nursing from independent living. So for example, in some communities within the healthcare center, they have a separate gym, or all of them have their dining rooms. And if a resident moves to the healthcare center, in some communities, they require residents to dine within the healthcare center dining room. Here at Horizon House, we have one gym. We're very intentional about that. So when a resident does transition to assisted living, if the resident desires and is able and wants to continue going to the gym, please go to the gym. Residents in assisted living have the option, if they're safe and able to do so, they can enjoy any of their meals in the terrace dining room. So that is the philosophy behind the integration here, whereas in some communities, there's a very clear line of when you make that move to the healthcare center, you do most of your functions and living only in the healthcare center. It's a very integrated model. And similarly, as an incoming independent living resident, they have to be okay with that too. And so that's why it's important to research different senior living communities, and I'm glad all of you chose Horizon House. In terms of some of the support and services, we have a very, Ildiko Pakali. She has done just a marvelous job as a life enrichment director. And here's a picture of our very own Sam, who just came into the room. Thanks so much, Sam. It's a great picture of Sam and Joyce. And Ildiko has just moved the needle on the life enrichment programming. You know, some communities still revert to the very traditional, again, nothing wrong, very traditional programs like bingo, a lot more movie watching. Here, Ildiko is really looking at evidence-based research and practices around engagement. And so there is a real big push for a lot of integration between assisted living and independent living with respect to programs. Always the question of transport help, of course, as you know, because many of our residents in assisted living need support with transportation and mobility. So it's a matter of relying, and we're so grateful to have all the volunteers we have in independent living to come and help, for example, with transportation to some of the larger community events. So Ildiko and her team are doing just a terrific job of really tailoring programs to meet the different levels of where residents are at with cognitive abilities and to play on those strengths. Volunteerism, I just mentioned, wellness services. Andrew and his team also support residents in assisted living, both up in assisted living with exercise classes. We have some independent living residents who come to assisted living to join the exercise program, so it goes both ways. We welcome and invite that too. Social services, we have a social service rep up there as well. And we have a registered dietitian, Jessica, who primarily is supporting residents in assisted living with the dietary needs, just because as conditions change, health changes, so oftentimes does nutritional need requirement changes. Housekeeping, again, we partner with Divya and her team as well for outpatient services and the same home health services I spoke about earlier. And there is Medora, who is thriving in assisted living. I'm really thrilled for her. Of course, as you are aware, we staff in assisted living 24/7 with licensed nurses, both in the form of LPNs and registered nurses. And we, of course, have our CNAs that we refer to as elder care assistants to help support residents with a lot of the self-care type of activities. We have the second floor has been more situated now to provide a broader footprint for residents with memory loss. And so that is really focusing on creating more areas within the floor for different activity stations, because as we lose memory, our world starts to shrink and we have less we can interact with. And it's very common for individuals experiencing memory loss to be looking for structure and looking for things to do. And so Ildiko has been very intentional as part of our master planning construction project up in assisted living. We're creating more pockets of spaces, smaller activity spaces throughout the floor to have more destinations for residents with memory loss, because the attention span is very short. They want to move on to something else. And so this is going to create more of that dynamic of living for those residents. Third floor is more tailored towards residents with physical limitations, mild cognitive loss. And so we're really being more distinguished between the floors to help support residents better in their lifestyle and programming. We do work very closely with the geriatric nurse practitioner in mental health. And so Brooke is her name, Brooke Katz. She is terrific. She comes in usually once every other week to help us support residents who are going through various challenges with dementia. And in the form of medication management, we always want to look at non-pharmacological behavioral strategies first. And there is a time and a place sometimes for medications to help support residents. And then, of course, we also partner like in independent living with hospice providers. And as I just shared, residents, when they make that transition to assisted living, there is sometimes a misperception, and it's understandable, this is everywhere in all communities, where if I make that move to assisted living, I'm going to be stuck there. I'm going to be locked up there. Absolutely not the case. We believe in an integrated model here. So for the residents who have transitioned to assisted living, if they're safe and able to do so, you will continue seeing some of those residents after they transition down in the fireside lounge, enjoying coffee, or coming down with the partners who may still be in independent living. We support and welcome that. Short-term stays, I mentioned already, somebody who has left the hospital or skilled nursing, not quite ready to go back to independent living, so they may come through assisted living for a few weeks. Sometimes it may be shorter, just for some more support and round-the-clock care. They'd rather have that than perhaps a home care provider in their apartment, in their space. I can tell you that that is one of the reasons why some do choose to transition to assisted living, is when they have a higher degree of home care, it starts to feel like an intrusion in their space because they're kind of just planted in your apartment. Whereas in assisted living, they only come in when you need something or need a care element of support, then they leave. So that is the reason some choose to transition. Or when there is a couple and one is the more well spouse, then it starts to become more of an intrusion of privacy on the well spouse. And so we do have, as I'm sure some of you know, some of these couples where one is still in independent living and one is in assisted living. So it's a hard decision. And I feel for couples who come to that decision point of when it becomes too much or the caregiver costs are too much, then it becomes a difficult decision, but the right decision for many to transition one partner to assisted living where they have that care and support. And then you can just be a spouse or a partner and not also be in the caregiving role. Jumping ahead to permanent transition. And I was just speaking about that in terms of a spouse who is serving as a primary caregiver. We have had situations where the caregiver spouse wants to take an extended travel, and yet the individual in need of support just can no longer travel. And so we have had residents come stay with us for a short-term stay while their spouse goes and does some traveling or attends reunions or graduations. It's a support network, or for the spouse who is just needing a caregiving break for the loved one who maybe has a dementia process. So assisted living can be that respite place. In terms of permanent residency and assisted living, I mentioned a little bit already some of these things. A resident is in decline. I will tell you that, again, our goal is to support residents in independent living for as long as possible. That's your goal, and that's our goal. And there comes a time for some, not all. Many independent residents never step foot in assisted living and pass away in their own apartments. And for those who do transition to assisted living, what ends up happening in many cases is residents start with home care, perhaps some with care management, and it no longer is the right kind of support. A resident who needs more consistent, longer hours of structure, it no longer is held together as well with home care or care management. And so in some cases, assisted living is the better alternative, where there is the stimulation of programs. When you're in independent living, you have to go out and seek how you're going to spend your time. Caregivers, there's a variety of private caregivers. Some are better at working with their clients in independent living and getting them out to programs. In assisted living, they are invited, they're strongly encouraged to come participate so we can make sure that residents have engagement. And that becomes easier in assisted living because we do see some residents beginning to isolate more and more in independent living. And sometimes even with some home care support, it's not enough or it's not the right type of support. So there are also some real beautiful benefits of assisted living to provide more of that structure and engagement that isn't always possible through other support in independent living. We have some residents who transition because of some significant chronic health condition changes that are requiring more nurse oversight that can't be met with home care because that's not part of home care. And so sometimes we do have some health changes that warrant assisted living. Mentioned already, a spouse is a private caregiver, or as a caregiver just no longer works for their well spouse who may be experiencing some of their own health challenges. And for some, it's cost prohibitive to continue paying for a high degree of home care. One-on-one private care, home care is the most expensive form of care. So for some, it's cost prohibitive to continue that expense. In terms of cost, again, assisted living anywhere is private pay unless you have a long-term care insurance. And if you do have a policy, you'll want to check to see if it covers towards assisted living. I will say that more and more insurance of those who are still even offering long-term care insurance, many of them have gotten better. It used to be, back in the day, long-term care insurance only covers skilled nursing because that's largely what was available. And now there is the emergence of adult family homes, assisted living, home care. And so long-term care insurance policies have expanded their plans to include more settings in which they will cover for care. So I encourage any of you who have a policy to check in and see what it does cover. In assisted living, we have the reduced rate day benefit that was part of your residency agreement when you moved in, depending on how long you've been here and what time frame you moved in. You'll want to check your contract to see how many reduced rate days you have. And that entitles you at any time of your choosing in assisted living a 50% reduction in the cost of assisted living. And it's a one-time use. Some residents choose to use that as soon as they go into assisted living, whether for short-term or long or permanent residency. Some choose to bank that benefit until their level of care is higher and more expensive. So it's a personal choice as to when you use your reduced rate day benefit. And some choose to use it to cover the elimination period that most long-term care insurances have. So it's very common for long-term care insurances to have an elimination period of 30 days, 45 days, some may have 60. And so some will use the reduced rate day to cover that gap before your policy kicks in. Cost for assisted living is a wide range, just like in independent living. There's two charges for that. One is the level of care cost, of which there are 7, and the other is the apartment. And so there's a lot of variables between 7 levels of care, as well as the type of apartment you choose. So that can be anywhere from $4,000 to $5,000, all the way up to a resident who is total care in a 1-bedroom apartment, up to $14,000, $15,000. In contrast, that same resident total care and assisted living, if in their independent apartment with one-on-one private care, would be paying about $25,000 a month. So that's where you have to do the math in terms of evaluating as your home care cost rise and possibly care management cost if you're using both. That's where you have to figure out, how can I leverage my assets for as long as possible? And a part of that is also looking at what is the condition of you and the age in terms of how long those assets will last you. So, care is not inexpensive. And it is a growing concern, of course, for our society as we have a growing number of older adults and how we're going to be providing care when it is so darn expensive. So that is an ongoing discussion, of course. The Medicare B benefits and assisted living, that would apply for things like durable medical equipment, therapies, labs, your physician visits, but room and board, as it's called, your apartment, your level of care, those are private pay unless you have a long-term care insurance, and that's standard across all assisted living. So in summary, thank you for holding up with me. In summary, we here at Horizon House support residents to thrive at their optimal well-being and provide a variety of services and support, some in partnership with others, both in independent and assisted living. So anytime you have questions or you have a personal circumstance that you want to further flesh out, this is, or you have a new condition, you've been newly diagnosed with Parkinson's, or you have a new diagnosis of dementia, or you have a partner who has a new diagnosis. If you want to come see me until we have a care navigator, please do. And we can talk about certainly what might be a scenario, do some scenario planning. I've had residents or family members come seek me out to just talk through scenarios. If my condition goes in this direction or my partner's condition, what might be some options, or when will I know when it's time to get some support, or when will I know when it might be time to consider assisted living? Please don't hesitate to reach out to me. I'm happy to meet with you one-on-one to talk about whatever your own circumstances might be and what support we can get in place for you. Any other questions? Yes, go ahead, Terry.
Is there anyone here who can look at and see what's missing in your paperwork? Review what?
I'd be happy to help with that. If you're talking about advanced directives, Nancy is another terrific resource, Nancy Nadelsky. She does that for many residents. And so Nancy is a great resource and even a better expert than me because she's spent a lot of time in end-of-life directives. Thank you, Nancy. I think I had Judith, and then I'll come to you, David.
I would just like to encourage that this session take place every single year, Lori. And do you think it will? So I would come again. This stuff is not that easy just to absorb one time.
Absolutely. Before the pandemic, I used to do this once a year. And pandemic just screwed so much up. I'm getting back over here for the camera because I understand I'm being recorded, and then I'll come back over. So yes, and what I find often, Judith, is this is all great information, but until you need it, it's not easy to remember. And that's why we have the Care Navigator role, is when you do have a need, we want to have that resource available for when I need help with something. And again, use me now as that resource because it is hard to track all of this. And there is so much information in terms of support options that's why we created this position of which most senior living communities do not have, because we recognize it's a changing target for all of us as we age and we experience different changes.
Will this be on the web, on the Horizon House web? Will this program today?
Nick is saying yes, it will be. When? In the next week. I think there's usually some editing that takes place, but yes, it will be up on HH Connect. Is that correct? Yes, HH Connect. Thank you.
Yeah,
Oh, she was asking, my apologies, Nancy. She was asking if the recording of this session will be available, and it will be on HH Connect in the next week or so. So if at any point in the future you think, I have a need, or I can't remember what Lori said about, you can go back and watch it. Or share with your family members as well. David and then Ina.
The program was excellent. One question. Do you know how to fix elevators?
I unfortunately am not a jack of all trades.
Lori, just a small thing, but it truly was indicative of the care that Horizon House that you provide. I had COVID lately, and I could not, I needed help with food, and you provided the service of delivering it for free. Now, it's not a big deal to pay for the delivery, but it made a difference psychologically that, yes, I can call down and get my dinner, and I don't have to worry about it. So thank you. Small thing, but very important.
In case you couldn't hear Ina was just relaying that when she was recently in isolation. During the pandemic, I was trying to strategize about ways to better support residents who might need to be in isolation. And I want to just caution everyone, I am cautioning staff, don't assume isolation means COVID. Isolation can be because of RSV, can be because of influenza, could be norovirus. So don't assume isolation translates to COVID. And so it was during the pandemic, however, was the impetus. And so we do provide accommodations. And so there is support for anyone who needs to be in isolation, because this is coming from a public health perspective. We want to support people to stay hunkered down in apartments so we don't transmit communicable infections and disease. So we do offer as an accommodation waiving the meal delivery fee for any food that is ordered from the terrace dining room or bistro, because we want to make sure you get food and nutrition. And the other pieces of those accommodations is if you need garbage or recycle picked up, we do ask that you call reception and they will dispatch a staff member to pick up outside the apartment. More and more deliveries happen nowadays because of the pandemic. So if you are expecting a delivery, call reception and they will dispatch a staff to deliver to your door. So we're really trying to support residents who need to be in isolation for any reason, to avoid the tendency to feel like, if I could just get out to go do this. If that mask is not worn properly, it's so easy for some of these communicable diseases or infections to slip out, those cracks and nooks and crannies of the mask. And that's what we're trying to avoid so that we can contain any transmission. And on that note, we do have an uptick in cases right now. If you're monitoring HH Connect, I have to update it again today because we have a couple more cases since it was updated yesterday. It is primarily in independent living. And I will tell you the pattern I'm seeing from most of the current cases is from travels. So word of advice is, if you're going to be traveling and going through airports, consider masking. This is the trend I'm seeing, not every single one. What I am monitoring very closely through contact tracing is if there is any linkage between the cases in Horizon House, because then that's when we get concerned about intra-community transmission. Now, we made it clear a number of months ago that we're not going to be in the business of shutting down, and thus King County Public Health instructed us to do so. But we'll continue monitoring, and we may put out a notice that we're encouraging mask use. We won't mandate, but we may be putting out a notice encouraging. We're monitoring it closely. Again, as of now, we have not found a linkage because most of the cases have just returned from travel, have been in the community for a day or two, weren't feeling well, tested, and are positive. So we'll be monitoring that, especially with a couple of cases of unknown. I really haven't been out much. Well, I was out outside of Horizon House, but then I also was here. And then we think, are there more cases yet to show up? I also want to emphasize that if you are feeling symptoms and you test for COVID, it is very common to be negative. Very commonly, people truly with COVID may not show positive until several days into an active infection. So don't be fooled. I'm pleading with you, if you are not feeling well, even if you test negative, please stay in your apartment because it could be COVID. And it is so highly transmissible that we want to try to contain that.
How many do we have?
I think right now, don't quote me, look at HH Connect. I know we have one independent staff member, one assisted living staff member, and I believe now no AL residents. We haven't had any AL residents since April, and I think we're up to 8 independent living residents. Don't quote me. I may be off by 1, but I think we have about 10 total. Couple staff, almost all IL residents, most having just returned from travels. Yes, Nancy? Is there a chance we'll have a nurse? You have access 24/7 to nurses for emergencies. So if you have a nurse need, you have a fall, you get a cut, you're not feeling well, you can choose to call for the nurse 24/7 and they will come and respond to you. So if you're talking about a clinic, no, we're not looking to reopen a clinic.
But it will be $50, right? It's $50 now.
Correct. If you call for the nurse and it's not an emergency situation, there will be a $50 charge, just as there would have been if you went to the clinic to get an assessment. But we really want to encourage that if you're not feeling well, call your providers. We want to preserve our nursing resources is the bottom line. And that's why we started imposing the $50 charge, is because the high volume of calls, even when we had the clinic, the clinic was only open several hours for several days a week. And so it was our assisted living nurses who were responding to calls from independent living residents, some of which were legitimate and some of which were self-care related requests. And we're trying to preserve nursing resources. As many of you know, there is a huge nursing shortage. We are fortunate to be staffed with the nurses in assisted living. We have longevity and stability, and we want to preserve that. And the reality is, for independent living, we're expecting, for those of you in independent living, to be independent unless you have an emergency, absolutely. But I will tell you that in most senior living communities, that service is not available. If they respond to any emergency, they send security or reception. And basically, it's to lay eyes on someone and say, call 911. I know that. It's not my hearing aids.
May I have your attention, please? May I have your attention, please? We are conducting a test of the fire alarm systems. This is only a test. I repeat, this is only a test.
I think I heard fire alarm testing. I do understand that the front desk does still have some donated test kit supplies. They are not available through free programs now. My strong recommendation is to have some on hand. You can check with your insurance company. Some insurance companies are covering towards the cost of home COVID test kits. That would be my strong recommendation. You also can order them off Amazon. And I think it's wise to have a couple on hand because we will deplete before long the supply at the front desk. We shouldn't rely on the front desk to have those test kits. That's part of your responsibility. But I do know that some residents didn't expect to needed one, and certainly were happy with whatever stash is left. Yes, Margaret?
It's really a matter
Oh, out of date. Thank you for raising that, Margaret. So on HH Connect, there is a link that you can check for expiration dates. I've had some residents who have struggled to find that and have called me. Absolutely fine. I usually, with someone on the phone, will just pull it right up off of HH Connect. I'll have you look at your box to tell me the date that it shows and then a lot number. Sometimes you might need a magnifying glass, so such small print. And then I'm happy to help talk you through whether or not it is an extended expiration date. Many of them have been extended, but at some point, those extended expiration dates really are expired. And of course, we have put out in the past a recycling protocol for your test kits that may be expired or have been used. So just a reminder that unfortunately, there's a lot of plastic components with the COVID test kits, so that would need to go in landfill, but there's also a fair number of paper, especially the instruction handouts. There's a lot of thick paper that you want to recycle, and any of the paper aspects of those COVID test kits. Anybody want to do a song or dance? All right. Thank you so much for the great questions. Don't hesitate. If you want to meet with me one-on-one to talk about personal circumstances, please don't hesitate to reach out. Have a wonderful day. Enjoy the sunshine that's finally with us. Thank you.